Hello po and magandang hapon po sa inyong lahat. First of all, I would like to thank the Philippine Statistical Research and Training Institute for inviting me to give this talk. I would also like to thank everyone who decided to attend this Research Forum 2021, especially those who decided to attend our session. On behalf of my collaborator, Ms. Charlene May Siloso, I hope that this afternoon you get not only insights from the talk, but I wanted to initiate a healthy conversation or discussion on registration of persons with disabilities in the Philippines, especially on monitoring and realizing the Sustainable Development Goals. The outline of this presentation is quite simple. First of all, I wanted to discuss why we needed to study and investigate this issue in the first place. Also, what does it entail, as well as how do we move forward or how do we proceed after learning about these things. So to be able to do so, our starting point is in the assessment of the available SDG indicators in the Philippines. SDGs have provided us with a blueprint which aims to stimulate planet-sensitive and people-centered changes to foster prosperity, peace, and partnerships, which of course strengthen global solidarity. All the member states have pledged to leave no one behind and to count the uncounted. But to be able to do so and thereby achieve the SDGs, it is essential that all countries generate quality, timely, and multidimensional disaggregated statistics. But before I proceed with the heart of the discussion, let me provide you with a very brief history first. Since its inception in 2015, the availability of SDG indicators in the Philippines was assessed to determine how responsive and ready we are and the Philippine statistical system is in addressing the data requirements for monitoring the SDGs. So in 2016, the PSBA board approved resolution number 4, which enjoins all concerned agencies to provide necessary data to be able to support and monitor the country's performance. In addition, in 2017, the Interagency Expert Group on SDG Indicators established the overarching principle on data disaggregation, which states that SDGs should be disaggregated by income, age, sex, race, ethnicity, migratory status, disability, geographic location, and other characteristics as mentioned and in accordance with the fundamental principles of official statistics. However, in looking at all of this, the reason really why we wanted to look at this aggregation is to relate it back to the initial pledge of studying the marginalized and special populations, because this enables their inclusion in program interventions, of course, in government planning, in budgeting, and providing the necessary services. But based from the latest assessment reported in the Philippine Action Plan, only 13 out of 63 indicators are complete with complete disaggregation. So this highlights actually the challenge faced by the PSA and the PSS in implementing the recommended disaggregation by the interagency and expert group. So in this figure, you can see the availability of SDG indicators with disaggregating variables as of May 2018. According to the report, there are no available indicators which are disaggregated in terms of ethnicity and indigenous status, as well as migratory status. Also, there is only one indicator for disaggregating by type of disability. If we read diligently these indicators, the terms disability or persons with disabilities are explicitly mentioned among 11 SDG indicators, as well as 7 mentions in targets for goals 4, 8, 10, 11, and 17. So as you may have noticed by now, we studied these indicators really closely in order to be able to anchor why we needed the concepts and definitions for harmonization. So this proposed registry framework came from the need to disaggregate SDG indicators by disability type in the Philippines, PSA collaborated with PSRTI to establish the registry framework proposal for data collection. Specifically, the proposal actually sought to harmonize the definition of disability and related concepts to be used by the national government and the related agencies in the Philippines. So this contains the following. First, the concepts and definitions, then the registry forms. It will also include templates for reporting, as well as a detailed and exhaustive list of implementing institutions and how the persons with disabilities are reported. It also requires QC or quality checking system, as well as some capacity building modules. But because this particular presentation is limited in terms of time, and the proposal we submitted and the final technical report we submitted eventually to PSRTI and PSA is at least 200 pages long, then I will just limit the presentation to the first two, which is the concepts and definitions, as well as registry forms. When we are studying all of these 6 aspects to be able to build the registry framework, Charlene and I realized early on that the process is not linear. And so we decided to build this workflow. In fact, we realized early on that while we're studying the proposed concepts and definitions and reading through how do we build the registry form and how do we proceed with quality control eventually, these topics and these particular aspects of the framework are interrelated, and we cannot discount that. That's why we came up with this proposal. And in particular, when we're looking at the proposed concepts and definitions, we also looked into the existing models of disability as well as some conceptual frameworks. We also studied existing national disability policies such as Batas Pambansa 344, RA 7277, RA 9442, and RA 10754. We also looked into not just the disability laws in the Philippines, but those of the other countries and their registry systems as well. We also consulted with stakeholders such as NCDA, NAPC, DOH, DPO, and of course, PSA. And in this entire process, we were able to study disability in terms of its definition. And there is a massive literature out there when you're reading research upon research on disability. And we're not just reading into it, we're also looking at how people are implementing the definitions and how countries are using these definitions and operationalizing them. So if I recall the entire process, which is so huge and so long in terms of reading, the most vivid definition of disability for me is that disability is actually an enigma in both the private and the public experience. In particular, when we want to study disability, we have to look at disability models first. And there are multiple reasons why. And the most important that I will highlight for this afternoon's discussion is because when we study models of disability, this provides us with definitions of disability. And given that disability is multidimensional, after the series of meetings we have with our stakeholders, it was suggested that the integral part of the conceptualization of disability involves 2 main models, which are the medical and the social model. Hence, as our starting point, we wanted to investigate the disability discourse involving these 2 models. So in terms of asking the question, what is disability? According to the medical model, an individual or medical phenomenon that results from impairments in body functions or structures, or it is a deficiency or abnormality. On the other hand, from the social model, disability is a social construct that is imposed on top of impairments by society, and there is a difference on how we look at it. Now, we also look at the perception towards individuals with disabilities. In terms of the medical model, it asserts that being disabled is actually negative. Whereas if we look at the social model, it asserts that being disabled in itself is neither positive nor negative. if we ask around and we keep looking at the definition, according to some, disability represents some form of personal catastrophe that has to be avoided if possible. However, if you look on the positive end of the spectrum, others view disability as a source of pride, of empowerment, and of course, as a redefining experience, which added value to the way we live our lives and what it means to become human. So if we look at these varying aspects and ways and views and perspectives in terms of the definition, we actually laid out not just two models, but all the models we can find, wherein the subset includes 9. So because if we view disability by just comparing the medical and the social model alone, this dichotomy is overly simplistic. It actually makes the whole thing sound simple, but in fact, it's not. So disability scholars actually have mentioned that the most common among these 9 models are the medical model, the economic model, and the socio-political model. And all the details of each of these models are listed, described in detail in our technical report submitted to the PSRTI. So if you wanted a copy, please don't hesitate to request, and we will give it as soon as we're able. So in terms of the definition, it's amiss if we don't look at the legal definition of disability as well. So as adopted from the implementing rules and regulations of RA 7277, RA 9442, and RA 10754, disability is a physical or mental impairment that substantially limits one or more psychological, physiological, or anatomical function of an individual or activities of such individual. It is also a record of such impairment or being regarded as having such an impairment. This definition is also aligned with the definition of Americans with Disabilities Act in 1990. In addition to this, the amended version of the Magna Carta states that persons with disabilities are those suffering from restriction of different abilities as a result of a mental, physical, or sensory impairment to perform an activity in the manner or within the range considered normal for a human being. However, this amended Magna Carta definition of persons with disability, though it is encompassing and inclusive, it includes the term suffering from, which means and relates disability closely to the medical model. And this is not in line with the human diversity principle of the United Nations Conventions on the rights of persons with disabilities, because it implies that persons with disabilities are constantly sick. So because of this discourse in terms of the definition, we studied it further in terms of the conceptual framework. So we did not just stop with the legal definitions, the scholarly research definitions, the public health citations, as well as the disability models. We also studied existing conceptual frameworks. So here, we present a couple, but instead of discussing them one by one, again, all details are available in the technical report we submitted to PSRTI. I will just mention the first and 2 more. So the first model in 1965 was presented by Nagy. Nagy actually viewed disability as a result from the interaction of a person with a health condition with his or her environment. And this includes family support, employer accommodations, and physical and social cultural barriers. Nagy also acknowledged that there are other factors affecting disability, including the person's own characteristics and perspective and definition of the situation. So from this starting point, which includes different components into the model, the Institute of Medicine in 1991 added several dimensions to the Nagy model, including 3 interlacing risk factors. This includes biological, environmental, and the third is lifestyle or behavioral. And as you can see, they added this external barrier on social and physical environment. Now, in 1997, the Institute of Medicine report was extended. So from the 1991 report to the 1997 report, the extension was made by making a clear reference on the importance of environment in causing, preventing, and reducing disability. So from this point, there is also an update from the WHO definition in 1980 from the World Health Organization to the 2001 definition, which is from the ICF, or ICF is the International Classification of Functioning, Disability, and Health. And it came up with a substantial revision of the ICIDH conceptual framework in 1980. So the framework that I will be discussing in detail or lengthily this afternoon is the last one, which is the ICF framework. So this actually reflects the way we think in the modern day about disability. It aims to embody a paradigm shift in the way health and disability are understood and measured. So the idea is, instead of the dichotomy of looking at people as with disability or without disability, we look at the entire idea of disability on a continuum with health, which means that there is like a level of severity. And it makes it possible to measure health and disability with the same domains of functioning. So based from this framework, ICF actually defines disability as an umbrella term. So because of the whole layout this way, it's an umbrella term for impairment, which is under the health condition, activity limitations, and participation restrictions. So you can see impairment, activity, and participation in this layout, as well as some contextual factors such as the environment and personal factors, or the mindset of the person having the disability, or with or without disability. So starting from this perspective, the notion of error in classification has to be studied. So if we define persons with disability in the Philippines following the ICF framework, then we have to be able to look into what other aspects of the decision making are we supposed to be studying, because there should be, it should not be that simple. There are issues and concepts and definitions that we still have to study practically. And this also includes the decision matrix, which we practically see in all Stat 101 classes. So there are errors in classification that we can make. So if we observe that the current registration practice fails in some sense, that some persons with disabilities are not issued an ID, then that's called exclusion error. So here, my arrow is not working. And this leads us with some problems, of course, when we excluded them. Some reasons discussed by the stakeholders as to why this happens are persons with disabilities are from remote areas or far-flung areas in the Philippines, and they find it difficult to go to the municipal hall to apply for an ID. Another reason why some people are excluded is because of personal choice, and that is they don't want to be labeled as persons with disabilities because of the stigma that the society puts into it. On the other hand, we also have the case of inclusion error. That is, a person is issued an ID even though the person does not have a disability. So some explanations provided by the stakeholders when these situations happen is that perhaps the disability type is temporary, such as a surgery, and of course, we cannot remove the reasoning that some people are faking their disability in order to avail of the discount. And this is one of the primary benefits allocated to persons with disabilities, not just the discounts, but also the priority lanes, etc. So not only do we have to take care on the definition of disability because of this possible error, because based on how we define persons with disability, we could be committing either the inclusion or the exclusion error. But apart from that, we also have to look at the cost of misclassification. In particular, what would happen if we give someone an ID even if they don't have a disability or they're not considered a person with disability, and vice versa. So if a person without disability is issued an ID, this can lead to serious economic issues. So for practical purposes, this should be an important consideration for policymakers because it affects the business and economic standpoint. If many customers are claiming the discount even when they are not entitled to it, then businesses will attempt to regain these losses by charging higher prices, and it affects everyone. Of course, on the other hand, if the person with disability is not issued an ID, then it is a human rights issue. Persons with disabilities are entitled to receive benefits and support from the government. So as you can see, it is not an issue to be taken lightly. We really have to be very careful on how we conceive this definition, and we have to be very inclusive. And in terms of the current framework that the Philippines have, suppose this outer rectangle is the set of all Filipinos, and this inner rectangle is the classification, the set of Filipinos classified to be persons with disability according to the social model. The further subdivision is that there are people who can be classified as persons with disability under the social model, but in fact, they're not according to the medical model. So suppose that the set of persons with disability is really in between those two models, but some persons with disabilities only have a temporary disability, whereas others have a permanent one. An example of a permanent disability is possibly blindness, wherein if you are blind from beginning, from birth, and it's not reversible, then it's permanent one. But an famous example of temporary disability is if you cannot perform self-care because you just had a surgery. So in this case, the classification using the medical model is a smaller subset. And currently what we have is that Filipinos with PWD IDs are those not necessarily all with disability. So in some sense, we have a subset here, which is they are well and healthy, and based on the complement of the definition of persons with disability, but they're given an ID. So we wanted to be able to capture a framework which wherein via the different models, the persons with disabilities are also the Filipinos with PWD ID. And this is the vision and the mission, of course. So in terms of looking at the concepts and definitions, before I conclude the entire discussion on it, let me just give you some insights that we were able to come up after performing a very lengthy discussion and face-to-face meetings, etc., in terms of studying the definitions of disability. And that is, to treat disability as fixed and dichotomous phenomenon actually leads to potential inaccuracies in our current methods of counting disability. So the Philippine population is best conceived not as those who do have a disability versus those who do not, but rather as varying on a series of continua that cover a range of disabilities and degrees of disablement. This indicates that disability is not a fixed status, but a continuously changing and evolving set of characteristics. Therefore, it is more fruitful for government agencies to conceive disability as fluid, continuous, and holistic. So with that said, let me pose the question to everyone, which is, what is the PWD ID for, or who do we give the ID? So is it for programs and policy development, or is it because of benefits, or is it because of other more important reasons? So now, reverting you back to the framework, So I already gave you an initial discussion on the proposed concepts and definitions. Let me go to the proposed registry forms, which requires some consultation with DOH because they're mandated by law to get and monitor this information, as well as to look into the existing registration practices in other countries. Now, as a snapshot, when we look at the disability registry system across the world, every disability registry system spring from some laws, some set of laws or disability policies that is enacted by that specific country. In order to investigate the registration practices and the reporting system, which is in this box, it is important that we have to examine the existing practices across countries as well as in the Philippines, of course. And we wanted to see how this translates to what we have and how the registration practices translates to how we implement the proposed framework, as well as how the laws actually translate into department orders and implementing rules and regulations, circulars, or issuances before they are passed down to the institution. So this is the fast part of the presentation, wherein I will be showing the existing forms across several parts of the country. But because it's almost election season, I would try my best not to mention any LGUs involved in this set of forms. So in this first form, as you can see, this contains 9 types of disability. If we look at the different form, this one only contains 7 types of disability with some subcategories. If we look at one more form, of course, the layout is different again, and there are only 7 types of disability, adding an option of, if it's chronic, then you have to secure medical assessment. There's a different version with 7 types of disability and another one with 7 types of disability with specific ailment. So what do we get from all of this? What we notice is that even if the DOH would release one form for every LGU to be able to collect information for the registry form for persons with disability, it is not consistently implemented across the country. So this is back in 2019, and more likely than not, it is still the same way that it's practiced as of today. But it is one of those practices that has to be monitored and we want to be able to change this system. So of course, that's a very, very high and ideal in terms of the way things are. And I'm not here to spew on idealistic perspectives, but I just wanted to be factual in mentioning that in terms of the forms, there are differences. In terms of the practices available in different countries, in our technical report, we presented some for those countries in Asia and some from European countries. But the one I will highlight in this presentation is how to apply for PWD assistance in BC, Canada. So the first step is to get a BCE ID. The second is to answer a 92-item online questionnaire to be followed by an eligibility interview, and of course, to fill out the forms. So the persons with disabilities application have 3 sections, one to be filled out by the applicant, another to be filled out by the doctor, and the third is to be certified by an assessor. So the current registry practice we have in the Philippines is that we have a medical certificate, and then vis-a-vis the personal information, then you can get the ID. Now, our proposal is to get the personal information and to have it to have the form answered by some medical practitioner and to be certified as well, following the BC registry practice. So this is a snapshot of the proposed registry form. First, fill out and sign the sections of Part A that apply to you. Next, to ask a medical practitioner to fill out and certify Part B. And then third, to send the form to a certified assessor or municipal social worker. So this is the form that we have submitted, we have worked on with some stakeholders, and then this is including all the 3 steps that I just previously mentioned. So the first part is to be filled by the applicant. This includes the typical information such as name and gender, age, etc. But I also wanted to emphasize that part of the first part, or part A, is the disability details coming from the Washington Group short set, which comprises questions on the 6. So these are 6 core functional domains on seeing, hearing, walking, cognition, self-care, and communication. So, and there is a level in terms of no or no difficulty, yes, some difficulty, yes, a lot of difficulty, and then cannot do it at all. So this is the short version of the form. But we also wanted to be able to ask the help of a medical practitioner in answering this form. In some sense, for vision, it could be a medical doctor, a nurse practitioner, or an optometrist. So in doing the part B of the form, we consulted medical doctors from PGH, DOH, and other agencies to help us write these questions. And we also have for hearing, walking or moving, self-care, self-care such as feeding, dressing, washing, grooming, and mental functions for everyday life. So apart from that, we also have the section on life-sustaining therapy, as well as the different classifications. So we asked the doctor to tick all the categories of disability that apply to the patient, but previously on part A, we also asked the patient to tick the categories that apply to them according to their perspective. So from the non-medical perspective, supposing that the applicant is not a doctor. So we also asked for the effects of the impairment, which is mandatory, as well as the duration, because this highlights the initial discussion I gave that the whole idea of disablement is not necessarily fixed. It could be on a series of continua, which could be like, instead of saying that someone is disabled or not disabled, it could have been temporary for a fixed number of time already, say months in this particular questionnaire. And the certification from the medical doctor is important. And from this, there's an assessment from the social worker. So finally, we reach to the end part of the discussion, which is what did we propose in the report? So our proposal is that disability results from the interaction between persons with impairments, attitudinal and environmental barriers that hinders their full and effective participation in certain activities or activity limitation, and interact with the world around them, or participation restrictions on an equal basis with others. So this is in line with the definition of the World Health Organization in their ICF framework, but we wanted to be more inclusive on how we define this definition. And of course, we were also looking forward into operationalizing this definition. So we came up with a flow chart on how to do that. So the first question is, do you have a severe medically determinable impairment that meets the duration requirement, or a combination of impairments that is severe and meets the duration requirement? If they answered yes or no, then if they answered yes, then the next question is, do you have an impairment or impairments that meets or equals one of the listings in Appendix A and meets the duration requirement? If they answered yes, then they are a person with disability. If they answered no, then we consider the assessment of residual functional capacity and the age, education, and work experience to see if you can make an adjustment to other work. And if you can make an adjustment to other work, then yes, you are not a person with disability, but if you cannot, then you are a person with disability. So we also provided a lengthy list of impairments in the report, including all the medical descriptions of this one. So this also includes the list of malignant neoplastic diseases in cancer and some immune system disorders. And of course, this includes not so popular skin disorders that are considered to be impairment as well. So with that said, I would like to acknowledge everyone who has been part of the construction, building, development, and conceptualization of this entire report. These are Mr. Mateo Lee, Mr. Randy Calcena, and Mr. Dandy Victa from NCDA, Ms. Maria Cristina Raimundo, Ms. Amor Espirito, Mr. John David Salonga, Ms. Mary Joy Padilla, Ms. Mayet Ostaco from DOH, Ms. Planning Grace Castillo, Ms. Raquel Sabeniano, Ms. Wilma Sulit from PSA, and we also have Doc Ferds from PGH and Mr. Abner Malapas from NAPC. From PSRTI, we have Megan Soroka, Sabro Masok, Jessa Lopez, and Dr. Josie Almeda, and of course, ANS Wilma Gillian from PSA. I would also, of course, heartily thank Cha for helping me to write the entire report. And thank you so much for your time and attention. Maraming salamat po.